Welcome and good evening. Thank you for joining our presentation this evening. My name is Michelle Zepeda, and I'm the program coordinator at Waterford Place Cancer Resource Center. Waterford Place provides programs and services free of charge for anyone impacted by a cancer diagnosis that supports whole person care. I would like to introduce our speaker for this evening, Dr. Meschi. Dr. Meschi is a medical oncologist at Rush Copley Medical Center who also specializes in hematology. He received his education from Medical College of Wisconsin and completed his residency at the University of Cincinnati. His fellowship in hematology and medical oncology was at Boston University. We thank Dr. Meschi for his time this evening, and I will now turn it over to him.
All right, thank you very much. You can hear me okay?
Yes.
All right, so I thought I would just start by going over a few definitions. In particular, I would like to define advanced cancer, locally advanced cancer, and metastatic cancer. So when we talk about advanced cancer, that's most often used to describe cancers that cannot be cured. So in other words, this means that the cancer won't totally go away and stay away completely with treatment. Some types of advanced cancer can be controlled, however, over long periods of time. When we talk about locally advanced cancer, some of those can be cured. Locally advanced cancer is cancer that has grown outside of the body part that it started in, but it has not yet spread to other organs of the body. So an example is sometimes a cancer can start in the brain and it is considered locally advanced, but it can be life-threatening because of its closeness to important organs or blood vessels. Some locally advanced cancers, such as prostate cancers, can actually be cured. And then when we talk about metastatic cancer, that simply means a cancer that has spread from the primary site to other organs of the body. Most metastatic cancers are referred to as advanced when they cannot be cured. And rarely metastatic cancer actually can be cured. A common example of that is testicular cancer. So when we talk about metastatic cancer treatment, our goals are to shrink the cancer, slow the cancer's growth, help relieve symptoms, and of course, help the patients live longer. So cancer cells must go through several steps to spread to a new part of the body. They must find ways to break away from the original tumor and enter into the bloodstream or the lymphatic system. They need to attach to the wall of or lymph vessel and move into a new body part. They need to find ways to grow and thrive in their new location, and they must be able to avoid attacks from the body's immune system. So when cancer spreads to a new area, it is still named after the part of the body where it started. And so this oftentimes can cause some confusion, since breast cancer that has spread to the lungs is called metastatic breast cancer to the lungs, not lung cancer. Treatment is also based on where the cancer started. So if prostate cancer spreads to the bones, it's still prostate cancer, and the doctor will choose treatments that have been shown to help against metastatic prostate cancer. Another example, colorectal cancer, if it's spread to the liver, it's treated as metastatic colon cancer, not liver cancer. So let's talk a little bit about one of the ways that cancer spreads and becomes metastatic, and we'll talk about the lymphatic system. Lymph vessels are much like blood vessels, except they carry clear fluid and immune cells. And cancer cells often get caught up in this lymphatic system and clog nearby lymph nodes. Here is maybe a little cartoon of what I was describing. Lymph fluid is clear. It's usually colorless. It's a fluid that occupies the space between all the cells of the body. It's oftentimes referred to as interstitial fluid, and it's similar to blood plasma. So it's about 95% water, and it seeps in and out through walls of very small vessels called capillaries. So if you look at the little cartoon, you can see these cells. I don't know if you can see my pointer or arrow, but these cells are tissue cells. And then here, this green part is like the beginning of a lymphatic capillary. And the green arrows kind of show that there's fluid that go around all of the cells, but then they leak into this capillary of the lymphatic system, and then it goes out towards the circulatory system. So the lymphatic system, it's connected to the circulatory system. It consists of capillaries, which we just saw, vessels, ducts, and lymph nodes. This system transports lymph in a one-way system back into the bloodstream. There's no heart, or there's no pump, but the lymph moves via skeletal muscle action, respiratory movement, and contraction of muscles and vessel walls. And if you can see the little cartoon here, the lymphatic capillaries, that's kind of where we were just the screen before. And then those capillaries drain into larger lymphatic vessels. These lymphatic vessels can go into lymph nodes, and then eventually it'll connect with our regular circulatory system. What are the functions of the lymphatic system? It has three main functions. It transports proteins, fluids lost by capillary seepage back to the bloodstream, which we just showed. It participates in the body's immune response. And interestingly, it is the pathway for the absorption of fats from the small intestine into the bloodstream. So, being said, here's like a bowel, and here's the small bowel, and you can see that these dark lumps on this membrane are lymph nodes that is draining from the GI system. Besides in the bowel, you can also see lymph nodes in the armpit area. You can see lymph nodes, throughout your body, but another common spot is in your head and neck area. Lymph nodes can trap and sometimes become swollen with bacteria that is invaded into the body. White cells accumulate there as well and can fight the infection. Here's some lymph nodes in your groin as well. Where the lymphatic system and cancer come into play is that lymphatic system is an important way, as I mentioned before, that cancer can spread. It's important to distinguish that spread of cancer from cancer that originates in the lymph nodes. Cancer that starts in the lymph nodes is called a lymphoma. But cancer that breaks off of a tumor and spreads into the lymph nodes is a different thing. And so a common example of this is breast cancer. Breast cancer typically drains into the lymph nodes of the axilla. This is a cartoon for a sentinel lymph node procedure. So the surgeon injects technetium and blue dye into the breast around the tumor, and they could follow the drainage into the lymphatic system and find the sentinel lymph node. This is maybe what most people are used to seeing, blood vessel. These are the cancer cells that go into the blood vessel. And for example, if you have an original tumor in your colon, it can get into your bloodstream and end up in a different part of the body. Here's another kind of cartoon showing that as well. So why do cancer cells, I'm gonna maybe move this, I can read my slide. Why cancer cells spread to where they do. So they get trapped in the next downstream organ or set of lymph nodes. As we just saw, that's why breast cancer often spreads to the axillary lymph nodes and not necessarily the abdomen. Many cancers spread to the lungs because the heart pumps blood from the rest of the body through the lungs. So it's a common spot for cancer cells to get stuck when it goes to the capillaries of the lungs. Managing metastatic breast cancer in general, patients need treatment that reaches all parts of the body. So it's the things that you would necessarily think about, and we'll talk about chemotherapy, targeted therapy, immune therapy, and even hormonal therapy. So every once in a while, when you are managing metastatic breast cancer, you may need a local treatment. And common local treatments are surgery and radiation therapy. And then another definition to keep in mind is palliative care. So palliative care is aimed at relieving suffering and improving quality of life. It helps the patient feel as good as possible for as long as possible. And it focuses on the patient and family rather than on the disease. And so we have a palliative care team that meets with most of our patients to focus on these things along with the oncologist. So certain palliative care symptoms are pain, depression, anxiety, shortness of breath, fatigue, weakness, loss of appetite, weight changes, nausea, vomiting, constipation, and ascites. So next, I was just going to talk about some things that we commonly encounter when treating metastatic cancer. So the first is bowel blockage. So cancer in the abdomen can sometimes block the bowels. That would cause severe cramping, abdominal pain, and throwing up. Pressure can build up and cause a perforation of the bowels. And it's important to know that when we see this, many patients are actually too sick and cannot tolerate surgery. If the blockage is only involving one area, a stiff tube or a stent can be placed usually by a GI physician, through the blocked area to keep it open, and you can avoid surgery. Operations such as colostomies and ileostomies may help. If surgery is involved, the surgeon usually cuts the bowel above where the blockage is and connects to an opening called the stoma on the skin of the abdomen. The stool then comes out into a bag that is put around the opening. If surgery or stents are not practical, then treating the symptoms is usually the best choice. The main thing that helps with symptoms of bowel obstruction is an NG tube. An NG tube is placed through the nose, down the throat, and into the stomach. The NG tube is attached to suction, which gently takes out the contents of the stomach, which relieves nausea, vomiting, and keeps the pressure from building up. Metastatic bowel obstruction is commonly seen in ovarian and GI primary cancers just because of their locations, but it also can occur when cancer metastasizes to the abdomen. And this could be a long, difficult problem to treat, so it's a common reason for admission to palliative care units. Presenting symptoms, we kind of talked about this before, nausea. There's mechanoreceptors that are triggered by distension in the bowel. Vomiting can follow nausea, but sometimes you don't have nausea and someone just throws up. Abdominal pain, usually around the umbilicus. If the pain is worse with movement or palpation, it could be something a little bit more serious. We talk about obstipation. This is lack of passing gas or stool, and that suggests a complete obstruction. But it should also be noted that some patients can have some overflow incontinence, so a little bit of diarrhea. It's caused by liquefaction of the stool by intestinal bacteria. And many of these patients have abdominal distension from that pressure that's built up, but you should also keep in mind that there could be some fluid in the abdomen as well that we call ascites. So a special type of bowel obstruction is called carcinomatosis, and that's small areas of tumor kind of spread throughout the bowel. It's very common in ovarian cancer. Because there's not one specific focal point, there's many small areas throughout the bowel. The symptoms can be gradual and slowly presenting for weeks to months. Here is kind of a typical bowel obstruction, like one point in the large intestine. I could imagine, a stent or something kind of helping that. But with a carcinomatosis, it's a much different story. Here is kind of a picture of what what the surgeon would see. All of these more yellow areas are tumor that's spread, and you can just see they're kind of layered all over the intestines, causing multiple points of obstruction and a lot of problems with motility in the bowel. So you can imagine this would be a hard problem, not as easy as just putting in a little stent there. Surgical approaches. So we had talked about how the surgeon can do a diversion. So in this little cartoon, you can imagine, here's the food coming into the stomach. And then, imagine this area, if you can see my arrow, is attached to this area, and that's where the obstruction is. So the surgeon cuts there and then attaches the small bowel here. So the flow can go through the colon, and this whole area back here is the bypassed small bowel. Oftentimes they'll cut this out and remove that, and so you're just doing a bypass. So everything can flow through. Another surgical approach is tumor debulking. So sometimes in carcinomatosis, this can go in and try and remove the tumors. And then we talked about diversion. Here's another kind of cartoon about that. So you can have an obstruction here in the descending colon. And so the surgeon would cut there, and then this is where the colon is brought to the skin, and the colostomy is here. And then this is the distal part where it's beyond the obstruction. And so this portion of the colon is removed. You can see this in the transverse colon as well. So surgeon would remove all of this. And then sometimes even higher in the GI tract, you can have an obstruction in the small bowel or the ileum, and the ileum is brought to the abdomen wall, and then the whole colon is removed in that case. And then another surgical approach, sometimes there's adhesions. So a lot of patients have had multiple surgeries, scar tissues, adhesions form. And this is just showing the surgeon, laparoscopically going in and removing some of these adhesions that that could be causing the obstruction. So sometimes patients don't make it to surgery. There could be several factors. Many times they're too sick. Many times they prefer not to go through surgery. There's also disease factors, like we had talked about. There could be carcinomatosis, too much tumor. There could be a lot of ascites or fluid in the abdomen, making surgery difficult. So if you can't do surgery, if you can't do stents, we manage these patients medically. And so usually the initial management is giving their bowels rest. So we have them nothing by mouth, IV fluids. There's some medicine that helps with motility, steroids, and that all important NG tube. If the obstruction starts to work itself out and the patient's improving, then we can advance to a liquid diet, or then eventually even a low residual diet. We treat their pain. If they have ascites, that can be putting pressure on the bowel as well. So we drain the ascites and use some medications for constipation. If after a few days things are not getting any better, then we usually do some more radiologic evaluations, talk to the surgeons a little bit more, and then we have to start thinking about nutritional support, because patients can't go long periods of time without receiving nutrition. So sometimes this can be a long process, and patients need what we call TPN, or basically we feed them through their veins. And so dietitians help us with this, and they make up a special bag for a patient, and they get fed that way as we try and relieve the obstruction. So moving on, as you can, so a kidney or the GU system is another area that can be blocked by cancer. So cancer in the abdomen can sometimes block the thin tubes or the ureters that carry urine into the kidneys or the bladder. Patients may stop urinating, urine backs up into the kidneys, and the kidneys stop working. In many cases, just like in the bowels, a stent can be threaded up from the bladder and through the ureters to keep them open and let the urine flow again. Another option is to put a tube through the skin right into the kidney and allow the urine to drain into a bag outside of the body. This is called a nephrostomy with a nephrostomy tube. And here's a little picture of this. This is a normal kidney. Here's the ureters that we were talking about draining into the bladder. And then here, if there's a cancer causing an obstruction, you can see the fluid backing up and causing the renal dysfunction. And here's kind of another picture of the same thing. All right. So moving on to bone metastasis. When we talk about bone disease, spine is the most common site of bone metastasis. Other common sites are pelvis. You'll see femur involvement a lot, or the upper leg, upper arm, ribs, and skull. And so it's important to keep in mind that bone is maintained by two main kinds of bone cells. So osteoblasts form new bone, and then osteoclasts dissolve old bone. When cancer cells block or speed up the action of either one of these cells, either too much bone is broken down or too much bone is made. Either of these changes are bad and can make bones break easier than normal. They also cause pain. We'll talk about cord compression in a second, and high calcium levels. So high calcium levels are something to take seriously. Some symptoms of hypercalcemia or high calcium is constipation, passing urine often, feeling sluggish or sleepy, feeling thirsty all the time, muscle weakness, muscle joint aches and pains, confusion, and kidney failure. Treatment is large amounts of IV fluids to help protect the kidneys, and we give medicines such as bisphosphonates to lower the calcium levels. And then once the calcium level is back to normal, you have to treat the underlying cancer to keep the calcium from getting too high again. So when we look at the types of cancer that like to spread to bone, you'll see the list here. Breast cancer very commonly goes to bone, and then lung, prostate, Hodgkin's lymphoma, kidney cancer, thyroid cancer, melanoma, and bladder cancer. Here is some pictures of bone metastasis. These are the femurs that I talked about. So a common area is the femur area. So you can see this destructive lesion in the bone. Here is a like a backbone, and this side should be the right side should be the same as the left side, but this all here is a cancer that's invading this pedicle of this vertebral body in the spine. Sometimes when you're working up a patient and you see something like this, the bone is so weak that it's very close to fracturing. So you have to send the patient to an orthopedic surgeon, and many times they could put in a pin or a rod or something to stabilize the bone to keep it from fracturing. If it does fracture, then they need surgery. Many times when they go in to do surgery, I have them send the tissue to pathology. Many times patients can present with a pathologic fracture, and that helps us with the diagnosis. And there's several different things the surgeon can do, as I talked about: plates, screws, cements, etc. And here you see another patient that had a pathologic fracture that needed a lot of hardware placed. If someone has bone metastasis and there's no fracture and surgery is not an option, we often treat them with radiation therapy, especially if their pain is hard to control. They have a great response rate. What happens is usually as the patient becomes radiated, you have tumor necrosis followed by collagen proliferation, woven bone formation, and replacement by lamellar bone. And then you see calcification of that area in about 2 to 3 months. Most of the patients respond quite quickly, and their pain is controlled quite quickly. Here you see, this is from prostate cancer. You can see prior to radiation therapy, and then this is what a treated bone met would look like after radiation therapy with that calcification. And then as a medical oncologist, I give bisphosphonates. We had talked about those before. Those are IV medications that strengthen the bone, prevent, we say, skeletal-related events or fractures, and also help with pain as well. So certain type of bone metastasis that deserves a little special attention is spinal cord compression. This is a big deal in our business. A mass effect from the tumor with associated edema results in ischemia and neural damage to the spinal cord. 10% of all patients with cancer actually develop this complication. And so here's a little cartoon of what that would look like. Here is your backbone. This yellow is your spinal cord, and here's the tumor putting pressure on the spinal cord, a very dangerous situation. So many tumors can cause cord compression. You see the list: breast, lung, kidney, myeloma, etc. When you talk about what level of involvement, the thoracic vertebral body is kind of your mid-back, so that's where we see most of the involved spine. Lumbar sacral is like the lower back, so 20% of cases involve the lower back, and then a smaller amount, 10%, could be up in the neck area or the cervical area. Pain is usually the first symptom. 95% of patients with a cord compression have back pain. Pain will precede other symptoms by weeks to months. Early cord compression could be asymptomatic. So symptoms besides pain is weakness. It often corresponds to the level of the cord involvement, spasticity of muscles, and then some abnormal reflexes. Eventually that leads to loss of feeling or sensory loss. It could lead to bowel dysfunction, bladder dysfunction, impotence. Treatment is steroids that decreases the swelling, and it's usually a drug called dexamethasone. And then it's important just to know that dexamethasone or steroids can also cause other problems, such as high blood glucose levels, GI bleeding, and it could exacerbate some mental illness. Surgery, we oftentimes call the neurosurgeon for an urgent consult. So if patients can have surgery, that's usually the preferred method of treatment, but many times that's not a possibility. Usually if there's a complete block and there's just one area with mild deficits, a neurosurgeon could go in and remove that. More likely though, it's radiation. Radiation therapy usually extends to 1 or 2 vertebral bodies above and below the level of compression. It usually is treatment lasting daily over 2 to 4 weeks. 2/3 of patients remain stable or even improve, and the majority achieve pain relief. So next, I was going to talk about brain metastasis. So this occurs in people with lung, or obviously can occur with all types of cancer, but most commonly with lung, breast, and melanoma. Usually there's single spots in the brain, but some cancer can cause swelling in the linings of the brain, not necessarily be a tumor, and that's called meningitis, or we say carcinomatous meningitis. Carcinomatous meningitis is often seen with leukemias and lymphomas, but can be with other cancer types as well. Symptoms of brain involvement with cancer include or depend on location, size, and number of growths in the brain and the amount of swelling. What usually happens is metastasis can push on or cause swelling in specific areas of the brain, causing symptoms. And it's important to know that sometimes we pick up brain metastasis without any symptoms. So, but most people do have symptoms. Symptoms are headaches, not being able to move parts of your body, like weakness, sleepiness, memory problems, changes in emotions or how a person acts, problems hearing, seeing, swallowing, seizures, or nausea and vomiting. Once again, we use initially steroids, that's to decrease the swelling. If someone had a seizure, many patients are put on anti-seizure medications. Surgery is an option if there's no more than 3 spots, but most of the time it's radiation therapy, and sometimes they can even do a special type of radiation therapy called stereotactic radiosurgery. Chemotherapy is usually not used because these or chemotherapy drugs have trouble getting into the brain. However, for people with meningitis from cancer, chemotherapy can be injected right into the fluid that surrounds the brain and spinal cord. This may be done through a lumbar puncture, but oftentimes we place a device called an Ommaya reservoir. This reservoir is a dome-like device that's placed under the skin of the head and accessed with a needle. Patients can get chemotherapy into the surrounds the brain and the spinal cord without having to get repeated lumbar punctures. And just to keep in mind, there are newer cancer drugs that are coming out all the time that can actually get into the brain. So your cancer team can let you know if this is an option for you. So a lot of the newer drugs actually, we're seeing some CNS activity. So this is just a little cartoon to maybe demonstrate that blood-brain barrier. Here is, blood vessel, and then outside, these are all the parts of the brain. And it's probably better to see in that upper right corner, this purple part is the brain, and then this is the blood, and these are the cancer cells. So they easily can pass into and invade into the brain and the cerebral spinal fluid, but these drugs, as you can see, do not get in there. So that kind of demonstrates that. Here's a picture of an Ommaya reservoir. So here's a little diagram. That's what I was talking about. We just inject the medicine here, and then it goes into the brain to treat the cancer. And then here is a picture of an Ommaya reservoir. Here's the hole into the brain. They place the reservoir there, and then the surgeon sews up the scalp, and that's what it looks like. Then the nurses just access this to give chemotherapy. And here's some pictures of brain metastasis imaging. So right here is the cancer, but you can see all of this white stuff is the edema or the swelling. So sometimes the swelling can even be worse than the actual cancer, or bigger, I should say, than the cancer. Here's another area of brain metastasis in the cerebellum. Some more pictures of brain tumors with swelling. And then this is an autopsy photo, and you can see the brain there. Here's just a picture of radiation therapy. And many patients need to wear a mask to hold them still. So let's move on to liver metastasis. Liver metastasis can occur from many types of cancer, but often colorectal, breast, esophageal, stomach, pancreatic, lung, kidney, and melanoma. So liver metastasis can be asymptomatic or cause a lot of symptoms. It all depends on how much of the liver is involved. Here are some symptoms that we see: loss of appetite, feeling tired or weak, fever, itchy skin, yellowing of the whites of the eyes or skin, otherwise known as jaundice, ascites, this bloated belly that we talked about, leg swelling, and pain in the right upper abdomen. If there's a lot of metastasis in the liver can't work well, and that causes a condition called hepatic encephalopathy that can cause confusion, sleepiness, and even a coma. Medicines to decrease one of the toxins, ammonia, are often given in this situation, and a common one is lactulose. Treatment of liver metastasis. Surgery may be an option if there's a small number of tumors and they're not in the areas that would affect normal liver function. You can radioablate or do an ablation of the liver. So a thin needle is put into the tumor and high energy current is passed through the needle to destroy cancer cells. Sometimes we can do stereotactic radiosurgery. Chemotherapy can actually be given right into a blood vessel leading right into the liver. And we can also do what's called an embolization. It's a procedure to block the blood supply to the cancer. So here is an example of liver metastasis. This is your liver right here. This is the cross section. This is your backbone. And the feet are towards us and the head is further away. So you're kind of looking up the body. And these, the liver should be all one color. So these arrows obviously are not normal, and that's where the cancer is. Here's another, you could see the big dark spots or liver metastasis. So just briefly talking about this radiofrequency ablation, there is this heat sink effect. So that's when that thermal energy is dispersed from the target lesion. Consequently, the shape and the size of the ablation zone may be unpredictable. So many times they treat the patient, bring them in, rescan them, and patients may need multiple sessions before completely eradicating the entire tumor. This is just a little picture of someone undergoing a radiofrequency ablation of the liver. And then this is just a little tune. Here is the ablation probe. You can see here are the different, the tips, and this is where the thermal energy is dispersed. And they're using like an ultrasound to get the probe right where it needs to be. All right, and then so moving on, we'll talk about lung metastasis. Most commonly seen with breast, colorectal cancer, head and neck cancer, kidney, testicular, uterine, and lymphomas. So as you can imagine, coughing is a symptom, bringing up blood when you cough, chest pain, shortness of breath, fluid around the lungs, decreased appetite, and weight loss. Treatment includes chemotherapy, immune therapy, or radiation therapy, or oftentimes a combination. Surgery may be an option if there's a small number of lung metastasis and there's no metastasis in other parts of the body, and the main cancer is under control. That's not that often, but that is a possibility to keep in mind. Treating the symptoms is important. Many patients have shortness of breath. When you are short of breath, many patients, as you can imagine, feel anxious, worried, and feeling like you're in a panic. So common medications that are used are opioids or a morphine-like medication that can to decrease the feeling of shortness of breath. There's also anti-anxiety medications that can be helpful, and then certain relaxation methods like distraction, a fan blowing cool air on you, those kind of things could help as well. Another common lung problem with metastatic cancer is effusions. So this is buildup of fluid around the lungs. The usual treatment is drainage or a thoracentesis, and we'll see a picture of that in a second, and then often antibiotics. Sometimes we can do a procedure to seal the space around the lung. That's called pleurodesis. And then in some that keep having recurring pleural effusions, a tube or catheter may be placed that can be left in place for a longer time, and the patient can drain their pleural effusion at home and don't need to come in for repeated thoracentesis procedures. So not the best picture. This is a tumor inside of a lung. Here you can see on the chest x-ray, these spots up here are not normal, and those are cancer. This is a CAT scan. Once again, you're kind of looking from upwards from the feet to the head, and these black areas are the lung, and this is the heart, and these arrows are clearly not normal, and that's metastatic cancer in the lung. This is pretty obvious, metastatic lung cancer. And then this is what I was talking about, the pleural effusion. You can see this is a normal lung, and you see that there's the this pleura, which is the lining around the lung, and there's a fluid that kind of bathes the lung. Well, sometimes that can get blocked, and there could be fluid that just builds up in this pleural space, and cancer often causes that. And then you see kind of a out of the lung. So in this chest x-ray, this would be a pleural effusion. So you don't see a tumor per se, but it's this fluid that's blocking out what should be a nice black aerated lung. And then this is a thoracentesis to remove the fluid. So the patient's usually in this position, and you can see the needle. You put the needle right into the pleural space, not into the lung or beyond the lung. But once the catheter and the needle is there, then that fluid is drained. All right, and so I just wanted to conclude by just talking about targeted therapy, and then we'll talk briefly about immune therapy and then be finished. So when we talk about metastatic disease, there are many targets on cancer cells that we are now being able to target for treatment. This is a cartoon of a tumor cell, and you can see they have receptors, and then inside of the cell, there's certain kinases or proteins and enzymes that all work together to cause tumor proliferation and tumor growth. And now we're doing so much work into finding specific medicines and treatment that can block some of these pathways. And so this is like probably the most traditional example of this, but we have medicines that target the HER2 protein in breast cancer. And this is a normal cell, and you can see even normal cells have this little pink HER2 protein that can be expressed. So normally we express a little bit of HER2, but in HER2 positive breast cancer, look how many more HER2 proteins are expressed. And then medications like these yellow antibodies can be targeted to the protein to cause the cell to die. Here's another example. Here's the HER2 protein, and then the medication comes, and then it just inhibits these intracellular signals. And so here's just a little slide that's showing all of the, just for non-small cell lung cancer, all of the specific drugs that target a specific mutation in a cancer cell. So nowadays, many times when the cancer is metastatic, we send for special next generation sequencing. We look for certain mutations, and we try and really pick a targeted therapy. And then even more, or what I should say, even more, or just as important, I would say, is immune therapy. And in particular, I'll just say a few words about this CAR T cell therapy and checkpoint inhibitors that are really changing the treatment of metastatic cancer. And then I'll also say that Dr. Patel, my colleague, has a talk later this month just on immune therapy, I believe. So he'll go into this in great detail. So I just wanted to kind of touch on it today. So as we talked about, your immune system is an organ in your body. Both of these therapies focus on the T cells. So they are a very important part of your immune system. And this is kind of a busy slide, but I just want to kind of show that there's two main arms of your immune system. This top arm focuses on T cells, and T cells actually go in and they're activated and they destroy antigens. And in our particular case, the antigens are the cancer cells. So these T cells actually are like killer cells, and they go in and protect us. The other arm of the immune system is the antibody-mediated immunity. So in this case, the cells make proteins called antibodies, and the antibodies go out and destroy the antigens. But we're going to be focusing up here on the cell-mediated immunity. And so this is just a little brief cartoon of what CAR T cell therapy is. So patients go to the clinic and they have a big machine that removes their T cells. And so the T cells are sent to a special lab. And in the lab, they actually insert a CAR gene into the T cells. And so the T cells look like this with this certain receptor that's coded by that CAR gene. The patients then receive chemotherapy to deplete all of their T cells. So the normal T cells are depleted with chemo, and then the new T cells with this gene, with a certain receptor, is injected into the patient. And these are the cancer-killing cells. And so here's another little cartoon to maybe explain it. This blue is the cancer cell, and this is the target that those T cells are going after, the CD19. And so when you look over here, this is the T cell. This is the gene that they're inserting into the T cells from the patient. And then this gene codes for a protein, this anti-CD19 CAR protein, that it didn't, or that sticks out cell surface and can attack the CD19 and kill the cancer cells. So that's the whole very basic way of how these CAR T cells work. And there's a lot of work in lymphoma, CLL, ALL, a lot of the blood cancer type of cells. And then here's a dramatic picture, anti-CD19 CAR T therapy. This is a PET scan, so PET scans light up when there's cancer, so you see all of the hot spots here, and you can also see the hot spots on this view as well. And then after 15 months, you see how nicely most of those lesions have gone away. We don't do that at Copley. Those are, it's kind of like in the order of bone marrow transplants. Those are done downtown and are very detailed. What we do use at Copley, and most cancer clinics use, and it's kind of bread and butter nowadays, are these checkpoint inhibitors. I will say, like, you know, tumors in your body, they try and disguise themselves from our immune system. And one of the ways they try and disguise themselves is by engaging with CTLA4 and PD1. So let me just, and then here's a common common medications. I'll show that in a second, but these are just an example. Like we now use, this is just for advanced non-small lung cancer. There are all these trials that look at immune therapy plus chemotherapy and all these different kind of combinations. So it's really improved our field a lot. This is the T cell that we talked about. And to explain this a little bit better, on the left side, you see all these receptors that are inhibitory. So these receptors kind of turn down the immune response. The receptors on the right side are activating receptors. So they go out and, you know, take care of business, so to speak. In particular, the T cell receptor is very important. And so the checkpoint inhibitors, they block CTLA4 or PD1 to kind of take away these breaks and allow this T cell and the T cell receptor to attack tumors. And so maybe another way to show that is here is a T cell. If you look at the tumor up here, this T cell has CTLA4 or PD1, and the checkpoint inhibitors block that and allow the T cell to attack the tumor cells. And just another way, I think, of showing it, here's CTLA4, the antibody against that. And now this tumor has the breaks removed. These breaks kind of go away, and the T cell can attack the cancer. And the last slide, this is kind of the same idea, but for PD1 and PDL1. So this very important T cell on the left, and then this tumor cell on the right. This is how the tumor cell is killed, this T cell receptor right here. But when there's PD1 expressed on the T cell, the tumor cell knows how to activate that. So the tumor cell is PDL1, and this interaction stops the immune response. And this is how tumor cells can go under the radar and not be attacked by the immune system. If you have antibodies to either the PDL1 on the tumor or PD1 on the T cell, and take this block away, then it just opens the floodgates, and this T cell can do business and take care of the tumor cell. So those are kind of exciting new ways that we are treating, especially metastatic cancer. And then, so this is I guess this is the last lung cancer trial when they first used immune therapy with chemotherapy. And you can see up here in February, that area of bright orange is cancer on both of these slides. And then after treatment, it goes away. So it's kind of dramatic, the before and after pictures. And I think that's it.